Well, good afternoon, everyone. I'm Nirmay. I'm one of the second year residents, internal medicine. And today we're actually having quite an interesting case. It's a case of Budd-Chiari syndrome, secondary tumor thrombosis. And of course, we have our big case presentation as a poster, but I want to just break it down so we can, go through each section. All right. So we're going to divide it as usual, case presentation and learning objectives, right? So I know there's a lot going on this slide, but I mean, just take a look at the images and just sit back and relax. Basically, we got this 67-year-old male with prostate cancer and aortic valve replacement who's on warfarin chronically. And he presented to us with worsening abdominal pain. So he had this abdominal pain for years, but it just worsened to the point that he just had to come to the ED, right? So nothing on the physical exam. He was massively distended and just a tense ascites on exam, right? So we started the workup and basically started a CT. And as you can see here, he had some pretty significant ascites and basically we saw an IVC filling defect in that CT, right? And now when someone's on warfarin, we usually tend to go, okay, maybe it was sort of failure of anticoagulation, right? So with that in mind, the picture was of quite an irregular filling defect. And our idea was to consult our vascular surgery team and sort of, do we need any IR technique or anything of that sort was our plan, right? And basically we contacted vascular who recommended that we're doing everything we can and just continue the warfarin. It doesn't seem like a failure of anticoagulation, right? And I've sort of omitted the other labs, but basically anything significant, he did not have a white count. There's nothing significant going on with his hemoglobin or just an elevated ALP. And the only reason I say that was you'll see osteopenia and, we're talking about prostate cancer linking this diagnosis, right? So his hospital stay was really unremarkable. I just had a paracentesis. Those labs were suggestive of transudative fluid and just given antibiotic for suspected SBP and albumin for cirrhosis, right? So this was the mainstay and he was discharged subsequently, right? And so just let's follow up with this guy. And what happened is he was evaluated the oncology team outpatient. And this time the patient was just complaining of this worsening abdominal pain to the point that he could not even lie flat. So it was affecting his daily life quite severely. And our oncology team had put him on chemotherapy, Leuprolide. As I mentioned, he was diagnosed with prostate cancer, right? So they did a PET scan just to see if there are any mets. And as you can see in this picture here, so what the PET scan showed was, of course, the prostate uptake. Besides that, lumbar spine and thoracic spine was having uptake, and as well as the IVC itself was having an update. So it turns out that the IVC filling defect was actually a seeded thrombus. Now, we don't know how the thrombus get there. Was it venous spread, lymphatic spread, peritoneal spread, but it just went inside the vessel and intraluminally blocked it. So with that, our discussion went to Budd-Chiari syndrome, which is, we'll talk about that more. It's an obstruction of the IVC. But at the end of the day, I think the family did want to go just to optimize this patient's comfort. And he did have a stent placement just to bypass that obstruction and went on the palliative pathway, right? So, and let's now talk about our learning objectives here. And by far, when we're talking about Budd-Chiari syndrome, the prevalence is 1 in 4 million. And in fact, the commonest cause is hypercoagulable states. And usually when we're talking about hypercoagulable states, it's we always go to factor V laden and stuff. Those are the common ones. But in fact, it's a myeloma that's actually the commonest one. Myelodysplastic syndromes are number 1, while our hypercoagulable states only account to 8%. And so it seems like in about 20%, the etiology is unknown, and that's sort of our scenario here. So let's talk about the pathophysiology. As there is flow obstruction, as you can see right here, sort of everything's going to just backflow, cause hepatic venous congestion, over time, hepatic pressure necrosis, hepatic liver injury, just biochemical liver injury going on. Of course, it can compromise the renal flow, ascites, as you can see, splenomegaly, which was not present in this patient, but it can happen, right? So prognosis of these patients is quite stable usually, but when you leave them untreated, their highly likely to go into hepatic cell failure. So the other point, and I think by far this is the most important slide, is how we work this up. And if you take a look, we start with always imaging first, right? Imaging and lab evaluations. And so once you've diagnosed Budd-Chiari syndrome, you got to find out the etiology, right? So as I mentioned, usually they say hypercoagulable panel is going to be the first line of investigation because that is the commonest etiology. And in our case, it was the PET scan that found the thrombus, right? The uptake of that tumor cell. That showed us the etiology. So when we're talking about treatment, basically we've got two arms, right? One is the symptomatic treatment and one is definitive treatment. So symptomatic treatment, just control the symptoms with pain medications, diuretics, beta blockers. And definitive treatment, I want to focus more on this, is of course, if you have a hypercoagulable state, it's going to be anticoagulation. And if you have a reversible cause that you can surgically extract, that is going to be the treatment of that. And one small note on TIPS procedure, that's basically the transjugular intrahepatic shunting. This shows a really good outcome of 78% 5-year survival rate. So that was something I wanted to mention on. So at the end, I just want to say that this case by far highlights the multidisciplinary involvement that we need in these kind of cases, and how we got to optimize for holistic care and think of the patient's functional status. So I just want to say at the end, I'm really grateful for this opportunity, both with this case for learning and this platform the SMA has made for us to discuss this. So any questions, please let me know.
Given that the patient was already on Coumadin for the valve replacement, is there anything else that could have been done to help prevent the thrombotic complication picture?
That's a great question because as we mentioned, right, the commonest cause is hypercoagulable states. Even cancer itself is predisposing to hypercoagulability. So as per what we discussed with the vascular team, they mentioned that we are putting the patient on the correct therapy. This guy was on warfarin 6 milligrams and his INR was in range. So I don't believe there's anything else we could have done as per the anticoagulation part, but I think this does come under just the sequelae of the tumor itself taking a different turn than usually it does, because as you know, prostate cancer is really, people live for about 10, 20 years without any issues. It's quite benign as compared to the other cancers. So that was something to know as well.